Ma'am, we are live now. We can proceed ahead also.
Thank you so much, Piyush. A very good afternoon to all respected dignitaries, faculties, and viewers of this webinar. Me and co-conveners of this series, Dr. Rachana Jaju, who is the chairperson of Amogs Mtp and Family Planning Committee, and Dr. Sujit Konkar, who is the chairperson of Website Committee Amogs. We extend a very heartfelt and a very warm welcome to all of you to this webinar. It's a great honor that we have Dr. Kiran Kuttakoti as our chief guest today. As we all know, Dr. Kiran Kuttakoti is President Amogs. And more than that, he is a good friend, philosopher, and guide to all of us. We are very proud to say that under his able leadership, we have been starting Maharashtra College of Obstetrics and Gynecology from this year. And to his credit, his phenomenal fellowships he has started in ART, endometriosis, cosmetic gynecology, and many are in pipeline. Not only Amoxians, but members all over India are taking participation in this, and they are running successfully. I would like to invite Dr. Kuttakoti sir to address the webinar.
Thank you, Dr. Rashmi. Today's guest of honor, Dr. Pardeshi sir, Dr. Vinita ji, Dr. Supriya Jaiswal, the convener, Dr. Rashmi, Dr. Rachna, and Dr. Sujit. First of all, a very warm welcome on behalf of Amogs to all the entire fraternity, not only Amogsians, but lot of Foxes. So good thing, Dr. Rachna, Rashmi, and Sujit, you have done is you have invited people outside Maharashtra to participate in this webinar. So thank you so much. And you know, Amogs is always inclusive. Many people say that Amogs should be inclusive. Yes, we are inclusive. And that is why so many of you are there. So many of you stars are there. Now coming to today's program is a highlight, will be a highlight on the MTP as well as the contraception. So we have excellent speakers. We have Sudesh, we have Basab, Dr. Shobha Gudi, who is the contraception woman of India, I would like to say. So wherever there is contraception and family planning, Shobha ji is there. So thank you, Shobha ji, for being with us, and Supriya ji.
Thank you.
Yes, yeah. And
very
again,
dubious distinction that is.
I don't know, but you know, for the past 3 years or so, just as whenever there is a topic of endometriosis, Dr. Ramani has to be there. So whenever there is contraception, Shobha ji has to be there. So it is like that.
Thank you.
So it's that similar. Okay, but it shows how much passion you have for this particular field. Okay. So thank you, and my best wishes, and I would like to appeal to all of you that our own Amogsians, Dr. Rashmi, Dr. Sujit, you know, they are going for the chairpersonships of various committees. Okay, so I would like all of you to vote for them and also canvass for them. And my best wishes, Supriya ji, also to you. So thank you. With these words, yeah, I would like Sujit and Rachna and everyone to take the program further. Thank you so much.
Thank you so much, sir. Thank you for those wonderful words of guidance. Our guest of honor for today, Dr. Rajendra Singh Pardesi, sir. Sir needs no introduction. He is always inspiring and guiding, always motivating us to go ahead, and has taken Amogs to a new level when he was the president of Amogs Society, and now Kiran sir is taking it more ahead. So we welcome Pardesi sir and would like to have few words from him.
Good evening, everybody. Respected chief guest and our ever smiling, ever active president, Dr. Kiran Kuttakoti. Guest of honors, always Dr. Vinita Singh and Dr. Supriya Jaiswal, Dr. Basab Mukherjee, our Amog chairperson, Dr. Rashmi Kar, Dr. Rachna Jaju, Dr. Sujit Konkar, Dr. Sudesh Doshi, and our seniors, Shobha Gudi. So, Just I wish to tell you about Dr. Rachana Jaju. She is very active chairperson of MTP and Family Welfare Committee, and she is doing really excellent work in Amogs. First, I wish to congratulate Rachana Jaju and Rashmi Kahar and Dr. Sujit for organizing this webinar reception MT. I wish every success to Dr. Rashmi Kahar for her future endeavor as chairperson of Practical Obstetric Committee in forthcoming elections. I wish every success to Dr. Sujit Konkar for his future endeavor as chairperson in Imaging Science Committee. Then I see Niva is there. I wish every success to Dr. Niva Mohan for her future endeavor in Foxy as chairperson of Ethics Committee. Wishing every webinar. Thank you so much for inviting. Thank you.
Thank you.
Thank you so much, sir. Our next guest of honor, Dr. Vinita Singh, Madam. She is Associate Professor, Department of OBGY, NMCH, Patna. Right now, she is the East Zone Coordinator of Foxy. She is consultant at the Care Hospital and IVF Center. She has held prestigious post of being President of the Patna Obstetric and Gynecological Society, Foxy ICOG Governing Council member, YTP Committee Chairperson, Joint Secretary, Clinical Secretary, Treasurer, Vice President, Ex-Executive Committee member of POGS. She has been a member of Safe Motherhood Committee, Quiz Committee, Practical Obstetrics Committee. She was Organizing Secretary for NYCCon.
Thank you, Rachna. Thank you very much. Thank you very much for such a kind words and such a good introduction. Yeah, so thank you. So very good evening, pranam, namaskar to everyone. At the very outset, I would like to thank Dr. Rashmi for inviting me as guest of honor in this prestigious Amogs Yuva webinar series organized in association with Amogs MTP Family Welfare Committee. It's really a pleasure to see a very dynamic Chief Guest President Amogs, Dr. Kiran Korikoti, who is always smiling and very active, energetic, I can say. The next is guest of honor. He is, I can say, he is my guide. He always show me the right path. He is my best friend, Dr. Rajendra Singh Pardesi. And of course, my dear Supriya, who is always, I say that she is my right hand. So today we are going to hear three brilliant speakers, Dr. Basav Mukherjee, Dr. Shobha Godi, and Dr. Sudesh Doshi, who will be talking on very important topics, that is contraception and MTP. So thank you very much for making me part of this program. At last, I would like to wish Dr. Rashmi, Dr. Sujit, and Dr. Nibha Mohan for the future endeavor. So I think they will come and they will be become the family. They are family of Foxy, but they will become as chairperson in Foxy. So once again, congratulations. I mean, all my best wishes, and thank you very much for making part of this program. Thank you.
Thank you, Vinita.
Thank you, respected Dr. Vinita, Madam. It is a great honor to have you with us today. Thank you so much for joining the webinar.
Thank you.
Our next guest of honor is Dr. Supriya Jaiswal. I call her Supriya D because she's very close to my heart. She is the consultant obstetrician and gynecologist, and we all know for her immense work as adolescent committee chairperson of Foxy. She has held many posts, like at present she's vice president of Patna OBGY Society. She's a HPV project of this zone, secretary and executive member of ISOPAP National ISAC. She has at certified center, and she's a recipient of many awards, and to her credit are many publications like Foxy PR on hygiene, focus on adolescent and Foxy on adolescent gynecology. It's a great honor, madam, to have you with us. I welcome you on behalf of our team, and I request you to kindly.
Time will be the same.
Thank you. Can you hear me?
Thank you.
Yes. Okay. So, very good evening to all of you, and I'm very much privileged to join this webinar that was Amogs Yuva webinar series 9, and you have made it in association with Amogs Mtp Family Welfare Committee. And that is such a wonderful curated program today. And I'm honored really to that you have made me the guest of honor here today, along with Rajendra Singh Pradesi sir, who's the mentor to so many people, and my own Vinita Di. I tell her always Vinita Di. She is also very, very close to me. I am close to her. So we have like sisters. She's my buddy Didi. So I'm very happy to have you have made me a guest of honor, and you have given me this honor on this platform. And the chief guest, the very dynamic Dr. Kiran Kurkoti sir. You have the moment you have become the president, you have taken it to greater heights, because you have I have seen so many programs with Amogs, with so many committees and the societies of Foxy. Then the conveners, the Rashmi Kahar, Rachna, and Dr. Sujit, they have done wonderful. They are all wonderful. And the Rashmi, you have done a great job by collaborating with so many people together. The speakers, we have got brilliant speakers, Dr. Sudesh and our own Dr. Basa Mukherjee. And then we have got wonderful chairpersons from all the societies. We have our own Dr. Shobha Gudi madam, who is going to speak on such a contraception for modern women. And so we have got our own. I'll just say my good wishes to all the people who are coming into elections, Dr. Rashmi, Dr. Sudesh, and Dr. Nibha Mohan. We have all best wishes to all the three people, and we really wish that they should come in Foxy. And really, thank you very much for having me today. Thank you very much. Thank you.
Thank you, respected Supriya madam. And it's time we proceed to our scientific session. I would like to request Dr. Sujit sir to kindly share the PPT, CBPPT, and make Dr. Basap sir co-host so that we can hear his PPT.
Meanwhile, can I introduce the chairperson for the first session then?
There is some technical problem for sharing from on my side.
So, Dr. Rachna,
our first chairperson for today is Dr. Asha Kumari madam. She is president of Bokaro OBGY Society. She is faculty at national and state conferences. She is ex-HOD at Bokaro General Hospital and has presented papers at AIS, MOC and DNB guide and trainer. We welcome you, ma'am. It is an honor to have you. Our second chairperson for today, Dr. Professor Pranay Fukan. He's professor and HOD OBGY at Tinsukia Medical College, Assam, teacher of undergraduate and postgraduate for 34 years, university examiner for MBBS, MS and PhD, ICOG visiting professor, AOFOG Young Gynecologist Awardee, president of the Dibrugarh OBGY Society, president ISOPARAB Dibrugarh since 2023, honorary secretary of Dibrugarh Menopause Society, has numerous publications in national and international journals, and has special interest in infertility and endometriosis. We welcome you, sir. I would request the chairpersons to introduce our speaker for today, Dr. Basa Mukherjee, sir.
Thank you. Dr. Basu Mukherjee. He is MBBS from Vellore, MD, Vellore FRCOG London, and Director, Ankuram Fertility and Fetal Medicine Center. His organization role is Force 2010 as an organizing secretary, Yuva Foxy 2012, Endogyne 2015 and 17, Boxcon 2018, and AICOG 2023. Post held is Vice President Foxy 2022 to 23, FIGO Regional Coordinator Safe Abortion 2017-2023, Secretary IRC India is President-elect Bengal Obs-Gynae Society, Vice President Kolkata Menopausal Society, Secretary IAG Bengal Chapter. Awards and achievements are Yuva Foxy Orator 2003, AOFOG Young Gynecological Awards, DC Datta Best Publication 2017, Appreciation Awards from Rotary 2018, as Secretary Box over 4th Foxy National Awards Pride of Foxy 2021. TRG member Family Planning, MOH FW, GOI, Clinical Examiner, MRCOG Part 3. Now I request Dr. Basu Mukherjee to continue his lecture.
Thank you, Dr. Ashal. Thank you very much. Very nice to see everybody here. Hi, Dr. Sujit. You were not there last time when I was just connected. So here we are. Thank you, Amogs. It's a organization which we all as Foxians are proud of. And anybody who knows Foxy knows what good work Amogs does. And any state who wants to meet a coalition of societies look up to Amogs as one of the leaders in that role, and how wonderful work all of you do. So just a time to say again, thank you to Dr. Pardeshi, my good friend Kiran, and all of you for inviting me and asking me to take that. Oh, I don't have screen sharing. You need to help me to share my screen. Rachna, if you can give me that privilege of screen sharing, Rashmi.
We are making
Sure.
Just a minute. Because together the whole technical team of Corona Remedies is engaged in something.
Okay.
Sir, so your comment, sir.
I got it. Oh, thank you very much. Thank you. Thank you. So yeah. So over the next 15 minutes, let's see, I'll take you through WHO MEC and the MEC wheel, as we used to call it before, and some very basic things about some matter which you would already know, and something which is more of a sensitization and encouragement to adopt this tool in your clinical practice, so that when you see patients, when you advise contraception, family planning advice, especially in women with some medical issues, then you would be more confident about prescribing these methods, and the women would be more confident in adopting them. So issues to address over the next 15 minutes would be generally medical, any medical problems. When you talk about family planning, there are a lot of myths and fears of the unknown which come into the picture. Am I doing her more harm than good? And is it in the best interest of the woman? Sometimes it gives a perfect excuse for women and the healthcare providers. They sometimes say that, oh, she had a problem, so I didn't give her birth control. But then you have to tackle with that unintended pregnancy and the miscarriage, which often has much more worse issues than the birth control method itself. Also, it gives a perfect excuse for women who sometimes don't want to use birth control, and they say, oh, I have this problem, so I thought it's not good for me. But again, the same woman comes back with an unintended pregnancy, and that's not in her best interest. So the risk of pregnancy with risks versus the side effects of contraception on the background of the existing medical condition is what all of us think about. All of us understand it, realize that this is the balance that we have to play. And then that's where medical eligibility criteria comes in the picture and helps us to make this balance. So careful history taking is a very integral part of when you're providing contraception, especially the first oral contraceptive pill. When you're giving that history, personal history, past, like what lifestyle she leads, about smoking habits, about alcohol, about drug abuse, family history of various medical illnesses, her past medical history, especially related to venous thromboembolism, related to the liver, hepatic issues, and other issues which may be important or contraindicate some of the hormonal medication, has to be taken before you offer her contraceptives. So now there's a WHO medical eligibility app. So in the second half of the talk, we'll talk about the app. Previously, there was used to be a wheel, and which was a blue in color, and which used to be mailed from WHO, and we used to get it in these conferences which we used to go, where there was public health topics and WHO or UNICEF was a part of. This was 20 years ago, and since then it's come a long way, the WHO MEC. So definition, it's a medical eligibility criteria for starting the use of contraception methods based on the WHO guidelines. It helps the provider to decide whether a particular contraceptive method can be used in the presence of a given individual characteristic or medical condition. Like so many people talk about obesity. So in obesity, can we give estrogen containing pills? Yes, we can give it. It's not a contraindication. But if she has other issues along with that, if she has hypertension, if she has dyslipidemia, if she has features of metabolic syndrome, then you need to be careful, and then possibly you may need to avoid it. So every condition is defined as representing either an individual's characteristics, that's either her age, her history of pregnancy, and other parameters, or known pre-existing medical diseases, which, as we said, will not be brought up sometimes by the patient unless you ask her, and that is important. So when you take a detailed history before offering her birth control methods. So purpose of the medical eligibility criteria is to base guidelines for family planning practices on the best available evidence, to address misconceptions regarding who can and who cannot safely use contraception, to reduce medical barriers, and to improve access and quality of care in family planning. So utilization of evidence-based information, the origin of all information and all of everything is research. So it's not it's evidence which comes from research. Experience comes much lower than that, but it's, of course, it is important. But evidence is what is the basis of where the medical eligibility criteria come from. So then they'll ask, like, how do you know that estrogen is contraindicated in this? How do you know intrauterine devices contraindicated in this condition? So that all has come from some evidence. Some always cannot be randomized controlled trials. Some would be case reports. Some would be anecdotal things. But at the same time, there will be some published data which would be utilized in giving these directions and giving these principles and giving these suggestions which are there in the medical eligibility criteria tool. So policies, strategies, job aids, and quality health services. So how does so this is a small snapshot at how you arrive at all these guidelines. So first you identify and review the evidence. So you identify the literature which is present in the world on that particular subject. There may not be a very wide amount of it. Then you find out what the quality of evidence is. And then you have a guideline steering group which would assess the examination and decision, no review, immediate review, or at the next review of MEC, and then the guideline development group, and then WHO does it. So this is just an important slide. It's 20 years, it's 10 years old, but it's still valid that if all women used modern contraceptive methods, then we would have 218 million less unwanted pregnancies, 138 million less abortions, 40 million less unsafe abortions, and 118,000 less maternal deaths. So generally in public health, we talk about two biggest interventions in the world which can make a massive difference. One is vaccination and one is contraception. You cannot save more lives than if you adopt these two and you try to push them wherever you can. So vaccination and contraception can save more lives than the IVF and the great endoscopy surgeries that you may be doing. So fifth edition of medical eligibility criteria was when they stopped printing this, and this was the last one in 2015. There have been modifications thereafter, and this is what the MEC wheel was. This is how it used to look. Still, there may be a few in some doctors' clinics, but generally this is what we used to turn it around and try to see what matches with what, and you know that the various criteria comes up where the category 1 has no restriction on use, 2 has advantages outweigh the risks, 3 risk outweighs advantages, and 4 is represents an unacceptable health risk where you can't use it. And because it was also meant to use at a community level where the knowledge and the judgment may not be so smart or so fine-tuned as the clinician sitting in a urban setting or a doctor who's more well informed. So it was category 1 and 2, just use it, and in category 3 and 4, just don't use it. So just to address the paraclinical staff, a lot of the people who directly deal with clients and the population who need birth control, we want to make it much more simpler, easier, and direct, straightforward. So WHO medical eligibility criteria for contraception 2015. This is when you spread it out. This is how it used to look. This is how it used to look before, and this is how it used to look. If you tear off the top part, then this is what was there inside. And in the back, there were a few A to Z, where each one had a point written, and it would come up on the screen. So the purple one, which was there, made was for India, because WHO doesn't always want all countries to blindly follow what WHO is saying. They say that sometimes countries have their individual characteristics and have individual data, which may be a little different from what WHO gets and wins. So you can use that as a background and also modify it. This was a modification which was done in India at one point of time, 2015-16. I think Dr. Sunita Mittal was very influential at that time in AIMS and in the ministry, and she was the one who led this the changes and the modifications at that point of time. So how it goes, I think all of us are aware, but just giving a couple of graphs. This is contraception if you want to operate in hypertension. If the diastolic is more than 100 and the systolic is more than 160, then of course it's a big no-no for all the estrogen containing contraception. So whether it's in the form of an oral tablet, whether it's in the form of a patch, a ring, or a combined injectable contraceptive, all those things where estrogen is there would not be recommended. Even if it is above 140 or 90, you would not be offering them estrogen-containing hormonal contraceptive methods as a first choice. What about POPs? Yes, you can give them. It's 1 and 2. What about the other ones? Yes, you can offer them other options. Yes, the LNG IUS may be also offered. Of course, the IUCDs can be taken there. What about diabetes? Again, diabetes, we know that if it is a long-standing diabetes where vasculopathies have taken place, where then, of course, or neuropathy or end organ disease, then you would have contraindications. But there are seldom people who come to us in such an advanced stage of diabetes in a reproductive age group. But if it's a woman who's on insulin, if it's a woman whose sugars are well controlled, she can use almost any contraception in the basket, as you can very well see from this graph, from this chart. So coming to the app, the last second part of this talk, the next 5 minutes, we'll talk about the app which is there. And of course, as a move from digital media, just before COVID, I don't think WHO thought that COVID will come, but this is 29th August 2019, when WHO launched its app for medical eligibility criteria for contraceptive use. Obviously, they understood that the blue wheel coming from Geneva and spreading all over the world is not working. You have to have something much more user-friendly, and that is where the app comes in. Of course, we live in a digital India, not a digital world also, where a lot of people, if they don't have anything, at least they have a mobile phone. So we have, I think the last statistics in India said that around 94 crore people have mobile phone of the 141 crore people we have in our country. So 94 crore mobile phones can all, and most of them are smartphones, which can download apps, and people, generally the next generation, as we all understand, are much smarter in dealing with phones, at least know better how to handle phones than us. So this is how it looks on the app. I'll just go through how it starts. So first, you of course have to install it, and you have an Android install or in the Apple. And this is how it looks. The dark blue on the top, that's WHO contraceptive tool, and this is how the icon looks on your screen. So that's it's circled in yellow. That's contraception, and it's also singled out so that you understand which is the one you need to download. And then after you download, there are different tables which are very user friendly. So once you go through them, then you'll understand that there is different medical conditions on which you can see the different types of birth control methods and which one is of which category, 0, sorry, not 0, 1, 2, 3, or 4, they will tell you. And also the methods are also listed, in which there is some details about the methods: emergency contraception, also antiretroviral therapies. So here there is, this is how it is lined up, where you have a fair idea. In the emergency contraception section, let's say you have information about COCs, the old use peas method, the LNG, and the copper IUD, which you can insert as an emergency contraceptive and continue as a contraception, and the ulipristal acetate UPA, which also is there. And there also there's a comparison of family planning methods, where you have they're trying to space out the ones which is most effective versus not that effective. And then there is a description about how to use the tool in case you want to have some time to read through that and you can't figure out what exactly to do. Then this is also something which will help you how to go about with it. So this is what I was telling you. They have much more information than was what in the wheel. So you have age, so different age groups. Once you press on that, on the arrow, on the small arrow which goes down, you will have a drop box where you will be seeing all the different conditions popping up. And so yeah, and then there is a place for your feedback. If you would like to give feedback to WHO, that would be good. So carry home messages. Remember that the effect of an unattended pregnancy in women with medical diseases often outweighs the effect of birth control on the disease. So it's important to really assess and balance what would be in the best interest of the woman. And for that, you would need some background knowledge and basic information, which would be there in the WHO MEC, because everything is, you cannot remember everything at all points of time. And to refer back to it, you can just flip your phone, open the app, and see where, if you have a doubt, what exactly is safe or in the best interest of the woman. Careful history taking before offering contraception and guidance from the WHO MEC app. Unless you know that she has a past history of problems, you really won't be you can't omit or just leave out that part of the information. It's important to take that part of the history and use it in clinical practice. Let us try to eliminate ignorance and fear and prescribe contraception where they need to, and not be afraid or not be deterred by women with medical diseases and problems. Thank you very much, Amogs, and thank you. I'll stop here. Sure.
Can we have a word from the chairpersons? It was an excellent and precise and crisp presentation by Basab sir.
Yes, Dr. Basu has presented his topic in a very nice way. He has elaborated everything in such a way that everyone will understand how which contraception should be given to which patient. Medical eligibility criteria is very important to prescribe contraception to needy patients. So that app, which is described by the Dr. Basu Mukherjee, that is also very important. So MEC will, and medical eligibility criteria for contraception is very important topic, and it is very newer topic. So thank you, Dr. Basu Mukherjee. You have presented your topic in a very nice way. Thank you.
Thank you. Thank you, madam.
Very nice, Dr. Basu. Very, very nice. Because I think it simplifies prescription, and a very strong message there that practitioners should get used to this and keep it available in the clinic at all times. It's very nice.
Thanks, Shubha. Thank you.
Thank you, Shobha madam. Thank you, Asha madam. I think Dr. Pranay Bhukan sir has also joined. We would like to hear his opinion also.
Hello, Namaskar. Hello. It is nice to hear to Dr. Basov. It's really the last point that he had mentioned. A lot of our patients are not exactly aware of the contraceptive benefits of the different methods, and then many of them, they cannot even exactly know that this is so beautiful. Products are available in the market as cafeteria methods, and we always use for attracting the patients, and we should make them aware. It is not only it is our duty, of course, the whole system should be involved, especially the education system and political system, and we should make our newer generations, future generations more aware of these beautiful products which are really very helpful to have a very nice world that we are going to have in the future. Thank you very much.
Yeah, Pranay, we always say, whoever of us have worked in this sector, family planning sector, that we often speak more about contraception, but we prescribe less. But lectures like this, it gives the strength and the courage to write down the hormones, because when it comes to prescribing hormones, there is always this hesitation, however senior a gynecologist is. But then when you have this evidence-based tool which tells you that, okay, in this condition, this is what is safe, and category 1 and 2, and I think that is a great thing to have. That's a great tool to have.
Exactly. Yes.
And Madam, it has really instilled a sense of confidence for prescribing MECB that it has done.
Yeah. Correct. Yes.
Thank
And
you.
they're convenient to use also. With what problem, what contraception is to be given. It's very easy to, see and prescribe.
Actually, we should be aware of the newer generation of contraceptives, which can be used as especially for PCOS patient as well as contraception for treatment. The newer generations of progesterone is all actually as a physician we should have the proper knowledge of these drugs. So that's very important to which patient actually these tablets fits. It's not necessarily we can give all the same medicine to all the patients, all the age group, and all the conditions. That is definitely we should be aware of that. Thank you.
Thank you so much, Rashna. If there are any questions, we can go ahead.
I think there are no questions in the chat box because it was a very informative and clear-cut message given by sir.
Thank you so much.
Thank you.
So, can we proceed to next session, Rachna?
Yes, ma'am, sure.
Will you please share the...
I am sharing the screen. Is my screen being seen?
Yes.
So
Yes.
I would invite the chairpersons for second session. Rashmi ma'am, will you introduce the chairpersons for this session?
Yes, it's a great honor to invite Dr. Biswajit Ghosh and Dr. Bibha Chaudhary Madam to chair the second session. As Dr. Sudesh Joshi is busy in an emergency, I would like to request Dr. Shobha Gudi Madam to proceed with her talk. I would like to introduce Dr. Biswajit Ghosh. He is Director Pran IVF at Hooghly and is a former associate with Akanksha IVF Center, West Delhi. He's with special training in IVF, IUI and ICSI for 10 years. Today he is with us to chair the session. Welcome, sir. And director at Tapaswi Multispeciality Hospital and IVF Center, Bhagalpur. At present, she is practicing in OBGYN. She's 38 years, infertility since 2010. At present, she's president of Bhagalpur OBGYN Society with special interest in infertility. It's a great honor to have you with us today, madam. We welcome you and we would like to request you to kindly introduce Dr. Shobha Gudi, madam, to the house. Dr. Biswajit, sir, if you are there. Dr. Rachna, you can go introduce.
It is with great honor and pride I would like to introduce Dr. Shobha Gudi ma'am. As Kiran sir had rightly said that whenever there is contraception, the first name that comes to your mind is of Dr. Shobha Gudi ma'am, and she is an excellent orator. She is a postgraduate teacher, examiner. She was past chairperson of the Family Welfare Committee, FOXY. She is president of the, BSOG. Then she is a board member of Family Planning of India. She is a peer reviewer of Jogi, and she is GCM ICOG 2021-23 and 24-25, President of the BMS, Chairperson of the Contraception Society of Isoparak, and she has numerous publications in national, international journals. She is editor of the Obstetric Hemorrhage, then author of Foxy Focus. She has received awards like CL Zaveri Symposium at AICOG, Shri Satya Sai Foundation Award, then she's a distinguished DNP teacher. She has received Best Society at Kasoga. So, and she has also received MS Signature Award. So it is with great honor and pride I would like to invite Dr. Shobha Gudi ma'am and would request her to go ahead with her presentation.
So just a minute, and sorry that I was just for a few minutes I was late. Apart from our formal introduction, everyone knows that Dr. Shobha Gudi, such a simple and dedicated person with such a broad vision, and I'm really privileged to chair her session. And because I had worked with her in her committee when she was chairperson, I was just his zonal coordinator in a family welfare committee, and I've saw her dedication with such a dedicated and with her sincerity. She worked day and night for her committee, and she has set the bar for the committee for such a high level. All the time she used to think that what next to do, what much to do for the society. And really, we should congratulate her for doing such a great work for the family and all the society.
Thank you.
So over to you, Dr. Shobha, for your talk.
Yeah,
Yes, the floor is yours.
Thank you so much. And
Sir, have you made Madam co-host?
Yeah, I think I'm. Yes, it's not enabled yet. Yes. Yeah, thank you, Nibha. It has been friendship like yours that has enabled us to work so well. And it was essentially teamwork, because a committee cannot function only with the chairperson. It is team building and teamwork. And I'm fortunate that I was well supported by you and others like you. And that is how I was able to perform whatever I could perform. But this is a huge, huge field. It is very vast. And I'm very thankful actually to the previous speaker, Dr. Basa Mukherjee. He was my predecessor by one count. After that, even Yashodhara Madam was the chairperson. And before that, Dr. Ritu Joshi. So these were the mentors for me, and they did inspire me to do a lot of good work. So this was a challenging field, and as all of us, we all understand that we see a need for contraception in our practice every day, but somehow we are not able to do justice to our women when it comes to offering them the choice and making them accept a method. Always there will be some barrier or the other. Is my screen visible, Nibha?
Yes.
Okay.
You can make it full screen.
Yeah, I will do that.
Yes. Otherwise,
I'll do that. Yeah. So thanks for the kind introduction, Rachna. And I must say that, Foxy needs more and more people like you. So all the best to the young Amogs team here, including Rashmi, you. And I'm very grateful to Dr. Kiran Koti for all the kind words he said. And as president, he has encouraged this subject so much and conducted so many webinars on this. I'm very grateful to him for inviting me here. Thanks to him. And also to the past president, Dr. Rajendra Singh Pardesi, who joined as the guest of honor. So with that, let me go ahead with this. And also to all the friends from Bihar who joined today. It is really lovely to see all of you. So our discussion today in about 15 minutes or so is what does the modern woman look for when it comes to contraceptives? And we will bring forward some of the newer options which are available apart from the methods which are already available in the public sector. But setting the context for the talk is this slide, which talks about contraception as need of the hour. And I think it is now a very, a kind of a stage statement to say that India has surpassed China's population. But contraception in everyday practice is not essentially thinking of the population. It is thinking primarily of the woman's reproductive rights. But for the Indian obstetric community, I think both go hand in hand. We have to think about the demography also as we talk to the patient in front of us. So the world population will reach 9 billion by 2050. Now, this is something which we cannot retard or regress in any way. This is the natural momentum that will happen, and it is bound to happen. And India accounts for 17% of all this. That is very, very huge. But as far as land area is concerned, it is just 2 to 3% of the entire land area. And when I look at India on the world map, it's a peninsular land, and I always feel, that it will go on shrinking, because that is how peninsular land is, because it's surrounded on all sides by ocean, except for this part. And this ocean always tries to overcome land. So I have a feeling that in the century to come, India may become a smaller country unless it grows northward, which is so much impossible because of the Himalayas. So therefore, we must think about our country for the next century also. And that means that we need to speak to women more and more about the options of increasing spacing at least between births, if not limiting the size of family, which also is very important. Now, why contraception is important is because most of the pregnancies that women carry in their wombs are actually unplanned. And quite often, they are untimed and unwanted as well. And it is because the conflict of ethical and moral values come that women do not seek abortion, and then they go ahead and they deliver them. So 2/5 of all pregnancies in the world are unintended. But if by some miracle we are able to meet the unmet need for contraception for all these women who fall prey to pregnancy, say for example, 49% of all pregnancies happening at any given time are unplanned. If we are able to prevent at least 50% of them, we will be having fewer abortions, and we will be having considerably fewer maternal deaths. Because what happens is that all these pregnancies result in a lot of burden on the healthcare system for catering to their emergency obstetric needs, etc. And somewhere along the line, failures happen, delays happen because of the sheer number. So we know all this. We know that India today has up to 27 million births per year, and it will do far better as a country if the number of births can be brought down. But we do not know that we can make an impact. So the obstetrician should feel, Indian obstetrician should feel, oh, I can bring down this reproductive wastage. I can bring down the number of maternal deaths by simply practicing the best of services in the field of family planning and contraception. So when we talk about the modern woman, there has to be a change in the approach by the service provider with better performance, okay, to try and bring about behavior change in women who can adapt better contraception, better understanding of the community where we are practicing, acknowledging the barriers and trying to navigate the barriers, not simply bypass it and go ahead and manage the safe abortion or manage the unwanted pregnancy, but try to be in time and prevent these pregnancies while crossing the myths and misconceptions of the acceptor, of the client and the couples and the families, addressing in their need for information, because often we fail to give them information, and overcoming our own bias that we cannot prescribe no medications and devices to nulliparous or young people, etc., and understand that there is a differential preference of method in the public and the private sector. So instead of comparing that public sector is doing so wonderfully well and the private sector is miserable in contraception prescription, we must try and understand that the need of the woman might be different, okay? And negotiating what cultural, social, and gender norms are existing there, building a supporting environment. And that is important when the family and community and the husband and the spouse comes forward and says, okay, I appreciate, use this method, I'm there to support you. Okay, so this is how some of the methods will look for. And, it should not deteriorate when we do not give information that the patient says, asks the doctor, ye property kya hota hai? And the doctor says, ये तो प्रॉपर्टी के ज्यादा टुकड़े न हो उसे रोकने का यंत्र है बस, इसमें आपको कुछ नहीं करने का है, it is not for you. So we shouldn't kind of have a system like this where there is absolutely no information given. So that is the reason we have to modernize our practice. We have to tell them absolutely that you cannot become pregnant when you don't want to. You have a life to lead. You are not a machine for producing children at such short intervals. You take a break, recover your health, become the woman you want to be, and then have the next pregnancy. So what is the problem is that incorrect or inconsistent use of contraception. This is the leading cause of unintended pregnancy. And, this is actually our data, and we can see that non-use of contraception is, the yellow is still very high, and incorrect use is quite high, and consistent use also has some method failure. So 1 in 5 women use contraception inconsistently or incorrectly. That is also there. So that goes on to show that we need to perform a lot better. We need to give information. We need to counsel. We need to do a lot of hand holding, and then we will succeed. So one good news, after sharing all that, I would like to bring in one good news that the latest NFHS survey, which happened in the midst of pandemic 19 to 21, that they found good results. They found that our mean contraception prevalence rate has improved to 56.5%, and the total fertility rate has in fact declined overall for the country. 41% decline in TFR since the inception of family planning program, because we have had the oldest family planning program in the world and a 55% increase in the MCPR. So there has a lot of focus by subsequent governments on this, but actually speaking, there is no cohesive effort by our community of obstetricians towards this. We need to have a very focused interventional approach. Now, this is something which has already been done by the previous speaker, and this is a very quick ready reckoner chart. It may be slightly outdated, but very useful still. It's a USA tool. It's available on the net, and you can expand it and put it under the glass top table of your consultation table, and you can look at it from time to time, because this gives the dark green, light green, orange, and red for category 1, 2, 3, 4, and that makes it very handy. And this is understanding the MEC wheel. This is the back of the MEC wheel, and I think Basab just told all of this, so I shall not go into this. And this is also the tool. So let us look at some of the options that the modern woman has today. And the one method which comes to the forefront of your mind is the contraceptive implant. So the subdermal contraceptive implant is here to stay. Finally, it is there in the public sector today. For more than a year, insertions are happening. The feedback, the follow-up is very, very encouraging. Very few requests for removal. I must say the requests for removal are far, far, far lesser than what is there for the intrauterine device. And if you look at how popular it is globally, it is immensely popular. More than 11 million women around the world use it. So if there are some 500 to 600 million women requiring contraception, a substantial proportion are using this already. Okay, and more than 100 countries, as you can see, and a top choice for women who are young and even teenagers in other countries. And I think it is a very suitable method because it's an external method. It contains a single rod, non-biodegradable. That means it needs to be removed at the end of 3 years. It contains a small quantity, 68 milligram of etonorgestrel, which is a synthetic analog of desogestrel. And it also contains barium sulfate and 25 to 30 micrograms per day release. Only microgram very small dose, achieves suppression of ovulation in the very cycle that you have inserted. Okay, and half-life and all is mentioned there, and how much it releases per year. Okay, for 3 years, and preloaded single-use applicator. It's a beautiful applicator. As you can see, it's a very beautiful with a very sharp needle. Actually, the needle is like a knife. It is very, very sharp. Okay, so one has to be careful. One has to get trained, and it has to be inserted here on the inner side of the upper arm and under local anesthetic. And these are the markings where it goes, and it goes just under the skin. And the beauty of it is that the woman can always palpate it, and then she can report to us if she is unable to palpate, and we can then reassure her or take it out if it has become impalpable, which is very, very rare. So we need to always tell women that this is a long-acting contraceptive, but it is reversible. Very effective. It's more effective than sterilization, in fact, 0.05% Pearl index. Very rapid return to fertility. You remove it, the next cycle the woman will conceive. User is compliance independent, just like all ARC methods. It is like a fit it and forget it, okay? And quite cost effective for that reason. There are also some beneficial effects, significant reduction in dysmenorrhea, premenstrual symptoms, some reduction of acne, reduced incidence of pelvic inflammatory disease and ectopic pregnancy. And there is good reason to believe that women with endometriosis will benefit in the pain scoring, just like the LNG IUS, these women will also benefit. So this is about the insertion, takes about 2 minutes or so, and the removal takes about 3 to 4 minutes or so. So that's what it says, and clinical trials show that very simple application and removal. We have been doing it for past few years now, and we find that the clients are very comfortable. Are there any contraindications? Of course, if there is any history of breast cancer or unexplained vaginal bleeding, or category 2 with caution when there are other drugs which the woman is using, if she's an epileptic or tuberculosis or HRV or antiretroviral therapy, HIV positive, or here the efficacy might come down a little, but otherwise it can still be provided. Follow-up is minimalistic. Only if she cannot feel or changes the shape or gets any of the side effects like irregular bleeding, then she can come and seek help, and we can provide her some solution for that. Okay. At follow-up, of course, if it is not palpable, there is always the option of imaging to check where it has gone. And if it is not in place, it needs to be removed. Troublesome bleeding, you must treat them symptomatically with simple drugs like tranexamic acid, mefenamic acid, etc. Sometimes even very low dose pills can be added for a month or so. And then if it doesn't settle, just rule out other causes also. Even if the woman conceives, which is so very unlikely, there's no harm to the pregnancy, and there is no recommendation for offering termination. And as a special category, women living with HIV will have MEC1 if they are on no drugs, but MEC2 if they are on antiretroviral drugs. Foxy has endorsed implant as a very strong LARC and should be a promising method to offer. Two statements have been there from Foxy. We come to the other method which is in vogue today, and that is the emergency contraception method. It is an easily available method over the counter, but sadly it is misused quite often, where couples try to use this as a, some kind of a ready reckoner, as we use the conference pamphlet. They use it to cover one single act of intercourse whenever it happens, and that does not protect them at all times. So there are good recommendations developed for this also. This is one of the wheels which has developed. In India, we use copper IUCD, levonorgestrel pills, and also unipersonal acetate also was available for some time. And emergency contraception becomes necessary when one of the routine methods will fail. Without going into the detail, I just wanted to mention unipersonal acetate, that this is a 5-day advantage over the 3-day LNG pill, that within 5 days of UPSI, unprotected sexual intercourse, it can be given. It also has effect in obese women, and it is more effective than LNG, okay, and less failure rate. And the only fine tuning is that if whenever you want to switch to an ongoing method which is hormonal in nature, then you have to give an adequate interval of 7 days. And in some cases, like some particular types of OC pills, a 9 days interval, but most often a 7 days interval will do. And if it's only POP which is being considered, then a 2 days interval is also enough. And the reason for this is that if we give it earlier than 1 week, the next method, then the emergency contraception may not work because essentially they compete for the same receptors. These are the MEC category for EC prescription, and you can see that most of it is category 1. The injectable contraceptive has also become modernized today. This is a very old method, has got excellent benefits for the woman. It is a LARC method. It has non-contraceptive benefits also. We have dipomedroxyprogesterone acetate available as an intramuscular injection, but what I would like to speak to you is about the subcutaneous injection, also very widely used, okay? And sometimes there is prolonged bleeding and spotting, and there is, of course, delay in return to fertility. Provides no protection against STI, which is true for all the LARCs which we are describing, and women have to use additional protection. Either they have to use condoms or the partner has to use condoms. All right, so on bone density, the fear is always there that injections will take away bone strength. Then what does evidence say? Evidence says that, you know, the women regain all the lost bone when they stop the injection. It is all you know, reversible, and it can be minimized by using good lifestyle and also supplemental calcium and dietary calcium. Long-term effect on adolescents is what is not known. So anyway, our prescription to adolescents is very restricted. So we need to concentrate on the adult age group. This is the subcutaneous one where the dosage is 30%, only 104 milligrams. And it can be self-injected by the woman after one training. And it's excellent because lower dose and the same efficacy. So these are examples of category 1 and 2 for the injection. It is really so versatile. And that is the reason it is known as the woman's best friend. All right, the best friend for women. So heavy smokers also, and women with a lot of gynae problems also, who are taking other drugs also, everything is category 1 for DMPA. And girls who are less than 18 years are category 2, that is okay. And women living with AIDS, it is category 1. So that is important. Then category, sorry. Okay, all right, this is further fine tuning. Category 3 is breastfeeding before 6 weeks postpartum and any history of DVT or hypertension. Current breast cancer is, of course, a contraindication. A word about the newer varieties of pills before I wind off my talk very, very quickly. There is a change in, there is a paradigm change in prescription of pills from the 21 days pill to the 24 days pill. And that is because it was thought that the 24 days pill gives less hormone withdrawal symptoms with lesser doses of hormones and avoids the unnecessary withdrawal bleeding sometimes, okay? And the central suppression is avoided, so withdrawal symptoms are less. So the 7-day hormone-free interval is reduced in the 24/4 regime as compared to the 21/7 regime. Okay, so this technique will add some estrogen to the 7-day hormone-free interval that improves the quality of life. These are some data which compare the 21 days to the 24 days with a significant p-value as far as the hormone withdrawal symptoms are considered, like pelvic pain, headache, breast tenderness, bloating, and use of pain medication, etc. And then there are the newer varieties of pill where estradiol valerate is being used along with Dynagist. Quadriphasic, 26 days plus 2 days. I'll come to it in the next slide. And then this is the molecule, the most modern estrogen, the estradiol, okay, native estrogen with selective action in tissues. If we are able to bring this forward with drospirenone or levonorgestrel, I think this is the most natural estrogen with the least side effects, but it is still not available. This is what I was talking about, Clara. This has recently come to the Indian market, and it has estradiol valerate, one of the natural estrogens, along with the newer progestin dynageist, which is very kind of, very time tested now because we have used it so widely for endometriosis. Okay, so here there is a step down dosage of estrogen and a step up dosage of progestin. You can see here the day 3 to 24 is using 2 milligrams of estrogen, the estradiol valerate, and day 3 to 24 is using 2 and 3 milligrams of dynagist in a graded fashion. Whereas the first 2 days and the last 2 days is using only estrogen, 3 milligram and 1 milligram. And this makes the woman very comfortable in the cycle. 27, 28 is placebo, and that is when the woman has her period. There is also this seasonal and continuous, continuous pills. Seasonal is for 84 days. Excellent choices for women with endometriosis or women who need pain management, even otherwise, or who need, control of HMB by postponing period, etc. So these are, we need to get adapted at prescribing these also, and very useful for young girls when they develop puberty menorrhagia, and maybe around 18 or 19 years. They are good options to give, because this is the time when their anemia can be easily corrected, and then we can switch them on to more cyclical therapy. The vaginal ring is not so popular now, not easily available, but believe me, it is one of the best methods, because vaginal route of absorption is extremely efficient. Okay, the vagina is a very efficient absorber of medicine. Etonorgestrel 120 microgram per day, and released along with ethinyl estradiol 15 microgram per day. So it is actually micro dosing, and every 3 weeks it needs to be replaced. This is the transdermal administration of transdermal is not available with us. Tropical countries, not very great, this thing, but option. But then it may come into the market soon, and then we'll learn more about it. And of course, see, this vaginal administration has got high acceptability and convenience, and avoids the first pass metabolism, the ring, and allows good absorption. Consistently low level hormones are achieved, which is what is desirable. So a lot of desirable options as far as hormone prescription. We need to become adept at it. If the ring comes back, my request to everyone is to vigorously promote it, because it is one of the best contraceptive methods for women. These are again the patches which are not there, and the sprays which are not there in India. So for us, if we increase the provider's commitment towards family planning, enhance the skill for prescription, change the attitudes, for example, PP-IUCD use in postpartum, intracesarean PP-IUCD insertions, encourage integration with other services, encourage digital technology to augment our service, and offer expanded basket of choice. Always offer the basket of choice. Give her all the methods, including emergency contraception. And we do have IEC material which we developed, so that can be shared with all of you. So the next few slides, a very rapid capture of what we did in the committee. This was the letter we wrote to the government stating our work for implant. These are some of the training sessions for implant that we did, and then that is the app, the Ask Tanu web Facebook page, through which contraception counseling is, the client can engage with the chatbot robo and ask questions about contraception. These are our launch sessions. This is FOXY, the integrated care clinics, which we tried to promote. So with integration comes a lot of better uptake of contraception, and this was launched by Dr. Poonam Shivkumar in Varda in her medical college hospital. I'm very proud to be associated with her, because she really helped in this, and it became a hit for them. They also brought out a paper, and I have also submitted a paper coming out from this, but essentially it is a Sevagram work, but we found that there was better utilization of contraception services. About 85 million unintended pregnancies are happening worldwide every year, and 40% are actually unintended. So this is one of my favorite slides from the UN Commission. UN endorsed contraceptive implants as one of its 13 life-saving commodities. So it's difficult to comprehend that contraceptives can be identified as life-saving commodities, and that is because it prevents the woman from the hazards of unsafe abortion, even otherwise abortions and unplanned births, etc., and the related morbidity and mortality. So when it comes to maternal health, we are familiar that, oxytocin, misoprostol, and now carbitocin, magnesium sulfate, they all have the potential for saving lives. But even reproductive health interventions as simple as female condom, contraceptive implant, and emergency contraception, preventing pregnancies in unplanned pregnancies in women will also go a long way to save lives. So family planning alone can bring more benefits to more people at less cost than any single technology now available to the human race, said by UNICEF. And we must firmly believe this, that pregnancy by choice doubles the joy and is an ultimate celebration of parenthood. But we must change the face of contraception and make it so much available for everybody that we do not have unintended pregnancies. And the sensibility and the sensitivity of the modern woman must make it possible for us to increase our contraception prescription at all times. I thank you very much for a patient audience. Thanks a lot.
Thank you. Thank you, Dr. Shobha Gudi, for your wonderful presentation. And the topic was so important, contraception for modern women. First of all, we must think who are the modern women, the recently married one, the younger ones, the highly educated, the high socioeconomic group. They are the they are the most casual ones regarding contraception. So beautifully explained about all the methods of contraception. And if we gynecologists should take responsibility for this to, do the counseling for contraception. And one thing about this implant insertion, is it everyone is doing right now, or is it restricted with the government only?
So it is available in the private sector. Only thing is a little bit of training is required. So if any organon people are coming and kind of meeting you, you can connect with the local organon team. They will facilitate. Even a virtual training is okay. It is a very kind of friendly
is a very simple
tool.
one. Yes.
Yeah, very simple.
But it seems the
even
Bihar
in
government
private
they have given this facility only to one medical college and one district hospital, and they have trained few doctors, and officially they are only doing. Unofficially also, no one is doing here.
In private, see, the government has never insisted that private practitioners must take training from government sector and then insert. They have never said that actually.
They have never done.
So
Yes.
From FOXY and from local societies, we can facilitate training
so
for
we
private
should go
doctors
on with
our own.
training
Yeah, we can
ourselves,
do
and
that.
we should go on putting.
Absolutely,
Because,
yeah.
yes, that's what I was thinking.
We are
that we must go ahead.
responsible. We are responsible for our own sector work. So if government gives us training, well and good, but they do not. They have restrictive training regulations. What to do? I am also imbibed as a government trainer, but I am not able to train private doctors under the government banner. So I have to do through organon, through local societies.
Okay,
if I have to train, I have to go parallelly. So that is the way to go.
That
because
is the
this
way
is
to
a
go.
safe. Gynecologists
Otherwise,
are very
they will
adept
keep on
surgeons.
restricted
What
way.
is there in inserting? Yeah, correct. But
Yes.
training is needed.
Yes.
Training is needed.
I
Because
don't-
we cannot go wrong in public health. Public
Definitely
health
not.
service,
Definitely
we
not.
cannot go wrong because this is not like clinical health.
No,
clinical health, women come with some sickness. All right. And we give therapy. Okay. So that has a different equation. In public health, contraception is a preventive service. These are essentially well women. They are coming to us to prevent something physiological, which is pregnancy. So the service has to be absolutely perfect. You cannot go wrong. Correct.
Yes.
Otherwise,
Whatever
it has
is possible should be given to them.
correct. The best possible should be given.
Best possible.
So thank you very much, Nibha. Thanks a lot for that.
Thank you, ma'am. I can see Dr. Ranjana Jha, madam, has joined the webinar. Welcome, ma'am, and we would like to hear from you.
I am extremely sorry for being late because I was in another webinar. Thank you, Dr. Rashmi Kahar ma'am, for giving me the opportunity. And all the topics are very useful. I had only Sobha Goody ma'am. But
You missed,
yeah.
you missed. There is another one still to go.
Now that webinar became late, na? So I missed all the. All the best for all the contestants, Dr. Rashmi, Dr. Sujit, and Nibha Mohan, ma'am. All the best. We are with you.
Thank you. And I would like to request Dr. Leena Baru, madam, and Dr. Vishwajit Ghosh, sir, to stay with us for third talk. Dr. Sudesh Doshi, we had planned his talk, but he is caught up in a dire emergency. So I would like to request Dr. Rachana Jaju to kindly proceed with her talk on MTP Amendment Act. And I would like to introduce chairpersons for this session. I would like to request Dr. Ranjana Jha, madam, to kindly chair this session. As we all know, madam is consultant OBGYN from Katihar Seva Sadan, and she is formerly associate professor MGM Medical College, Kishanganj. And she is presently vice president Katihar OBGYN Society and former secretary of Indian Red Cross at Katihar. We welcome you, madam. And I would like to introduce Dr. Leena Baru. Madam is a professor at Department of OBGYN at Bimsar Barla, and she is secretary of Barla OBGYN Society, life member of FOXY, ISOPAP, IMA, ISAR, and to her credit are many publications and research articles. Heartfelt welcome to you, madam. And I would like to request our MTP and Family Planning Committee Chairperson of Amogs, Dr. Rachana Jaju, to kindly deliver her talk.
Ma'am, is my screen?
Yes.
See? Yeah.
Yes, it's visible, Rachna. Make it a full screen. Otherwise, it's
Yeah, ma'am. Yes. Yeah, now it is okay?
Yes, fine. Right.
Yeah. Thank you so much for this opportunity. This was a sudden surprise for me. And after such stalwarts from the field speaking, and then a person like me speaking, you just have to cope up with me. Thank you so much. At the outset, would like to thank our chairpersons for chairing this session today. And my topic today is MTP Act, nuances and documentation. So now MTP is a choice of the pregnant woman, and MTP should not be denied for any pregnant woman, even if she's not planning to have any concurrent contraception. MTP should not be denied to that pregnant woman, and it is the obligation of the state also to protect her life and hence also provide for the protection of the fetus. So earlier, the MTP Act 1971 was framed, and the act actually did not need much of amendments. It was a very nicely framed act. It was regulated in 1975, and then amendments had taken place in 2003, and the recent amendments were there in 2021, which were published in Government Gazette on 25th March 2021. So this is how it has gone. The cabinet has approved the bill in 2020 January. It was introduced in Lok Sabha, then passed in Lok Sabha, later passed from Rajya Sabha, and was published in the Gazette on 25th March 2021. So under IPC, earlier, terminating a pregnancy was considered to be a criminal offense, and MTP Act allowed termination of pregnancy under certain situations for specialized persons like doctors or diploma, which is recognized by MCI and now NMC. So this is how it has come into the Gazette, and there are 4 important points of the Act: who should terminate it, when, where, and the documentation of the Act. So Any medical registered practitioner can terminate pregnancy provided his name is entered in the state medical register and he is qualified under the Indian Medical Council Act. So this is for a routine practitioner, and if you're doing an MTP beyond 20 weeks, any PG degree or diploma or an MBBS who has completed 6 months of house surgery in OBGY or has an experience of at least 1 year in OBGY at any hospital is allowed to terminate the pregnancy. Now, opinion. So opinion, if it is less than 20 weeks, according to the recent amendments, one registered medical practitioner is sufficient to opine that pregnancy can be terminated. If it is between 20 to 24 weeks, 2 medical practitioners signs are required. And if it is more than 24 weeks, then medical board comes into picture. So every state is required to constitute a medical board at every district hospital at least. And the members that are to be included in the medical board are a gynecologist, a pediatrician, a radiologist or a sonologist, or any other member which is to be notified by the state government. So what are the powers of the medical board? Now, medical board has power to allow MTP to be taken place, or they can deny. Now, they will take into consideration the whether the procedure is safe for the pregnant woman, or whether the fetal malformations that are present are having substantial risk to be incompatible for the life, or if the child is born with physical or mental abnormalities to be seriously handicapped. Once the medical board decides on termination, then they can advise you for additional investigations. So the functions of the medical board are to examine the patient and her reports, and provided the medical board forms an opinion, it has to be given in Form D, and it has to be given within 3 days of when the person approaches the medical board for the request of MTP. And to ensure that once the medical board has given the permission for terminating the pregnancy, then the whoever is guided has to do it within 5 days of the receipt of the request of the MTP. So that was regarding the medical board. Now, what are the indications? We all know these indications: to save the life of the mother, to prevent grave physical or mental injury to the mother. Then, if a child is physically or mentally congenitally abnormal on the grounds of rape, that is humanitarian ground. And now the recent amendment says contraception failure. Earlier, it was only for married women. Now it is for both married and unmarried women. So these are the indications. Now, beyond 20 to 24 weeks, survivors of the sexual assault or rape or incest minors, then there is change of marital status during the ongoing pregnancy. Suppose the woman got pregnant and later has been widowed or is divorced, then she can go for MTP. Women with certain physical disabilities, mentally ill women, including mental retardation and fetal malformations, which are incompatible with life, women with pregnancy on humanitarian setting, in humanitarian settings, such as if there is emergency like COVID, which was declared by government, then she is entitled to terminate the pregnancy. So these were the indications till 20 weeks, then 20 to 24 weeks. Now, if it is beyond 24 weeks, only indication which is given by the government gadget is the pregnancy is the baby having fetal malformations, and no other indication is given. So now, where is the place to be terminated? Up to 8 weeks, any PHC or a district hospital can terminate it. Then up to 12 weeks, district hospital, and up to 24 weeks, district hospital, and beyond that, it should be medical college. And secondly, a place like ours, the government private setups, which are approved by the district level committee. So what are the forms that are necessary? First and foremost, consent form, that is Form C, has to be filled. And then the opinion of the registered medical practitioner. If is less than 20 weeks, Form 1 is to be filled. If it is between 20 to 24 weeks, then Form E has to be filled. And if it is the medical board which is giving the permission, then there is Form D. And the forms which are done, Form 2, that is Roman 2, the monthly reporting form that we send to the district authorities, and Form 3 is the admission register, which we keep for the case records. So these are the mandatory forms: Form C, Form 1, Form E if it is between 20 to 24 weeks, and if more than 24 weeks, then Form D. So these are the forms, consent forms we can see. This is Form E, which is given by the government for 20 to 24 weeks. And if medical board approves, then this is the Form D, and it is in such format that has to be given. Now, this is a monthly reporting form which we all send to the district authorities. This is Form 2. And the register which we have to keep. So we have to preserve the records for MTP for a period of 5 years, and the paper of the MTP has to be kept under the custody of the owner or the head of the hospital, and it is not to be shown to anyone, only to the concerned authorities or appropriate authorities. So Form C, Form I, Form E, once the procedure is done, once you have taken the patient, you have done the procedure, all the documents, Form C, Form I, are to be kept in a sealed envelope and are to be shown only to the appropriate authorities. So now what are the indications? I think we have gone through the indications. Now, what is the complete procedure? Once the patient has come to you, you judge and counsel the patient, and you take the consent of the patient in the Form C. Now, once you have taken the consent, you go and fill the Form I, that is your doctor's opinion form, and you complete the actual procedure. Write down the papers of the actual procedure and put them in a sealed envelope, and which includes Form C, Form 1, and Form E if it is more than 20 to 24 weeks, and keep it in a sealed envelope. Now, usually what happens is we do the procedure, but we usually tend to forget to take the signatures, or at times the form is not kept properly, or it is not kept in a sealed envelope, and there is someone visiting you and they are saying that we need to check the form, and then you realize that, oh, I have not taken the signature. So make sure that you go stepwise. So this is a slide I have taken from Ajay Mane sir, and I really like this slide. So the stepwise thing is very important. Once you complete the procedure, however busy you are, you just put everything down and put it in a sealed envelope and hand it over to the owner of the hospital. And on the top of that envelope, you have to write it is a secret or a confidential thing. And every month before 5th, we send the monthly statement to the district authority. So this is the complete procedure. Now, protocols for MTP, we have to take a detailed history, general physical examinations which are required, then pelvic examination and investigations. Now, many of the patient, there is always a dilemma whether USG has to be done for the termination of pregnancy. See, it is not mandatory to do a USG for that patient, but ideally for the safety of us, USG has to be done, and it has to be kept with us as a record, because if we miss on anything, then they will take us into action ki this thing was not done, you have not kept the proper documentation. So it is mandatory for us to keep USG for our own safety. Now there is this we think we have done. And now one more important thing is that no registered medical practitioner should reveal the name or any other particulars of that pregnant patient under the MTP Act. So the law says that the identity of that patient is not to be disclosed, or it is punishable with imprisonment, which may extend up to 1 year, or with a fine, or both. So confidentiality is very important in MTP Act. Now, there were several. Why was the act actually amended? Because there were several cases filed in the Supreme Court seeking permission for aborting pregnancy beyond 20 weeks, and on the grounds of fetal abnormalities or pregnancies due to rape. So the act was amended, and everything was taken into consideration. So what are the punishments that are offered if we are terminating the pregnancy? If the person is unauthorized, then 2 to 7 years of rigorous imprisonment, and for the person who is performing MTP, if the place is unapproved, then again 2 to 7 years of imprisonment for the owner as well as the person who is performing MTP. And if there is failure of documentation, record keeping, or if you are not keeping the records properly, then there is fine of ₹1,000 plus 1 year imprisonment to the concerned person. So now the amendments, up to 12 weeks, advice of one doctor is needed, and up to 12 to 20 weeks, earlier it was 2 doctors, now it is 1 doctor. Earlier, 20 to 24 weeks was not allowed, now 2 doctors from some categories are allowed. Then more than 24 weeks, it is not allowed, only medical board will give the permission to do it. And anytime during pregnancy, 1 doctor, if immediately you have to save the life of pregnant woman, then anyone can terminate that pregnancy if it is life threatening for that woman. So here the amendment in 2020 specifies that any device or method used by any woman or her partner, which is it does not specifically say that it has to be a married woman. It can be any woman and her partner who are not using, who had an unplanned or an unwanted pregnancy. She can be either single or an unmarried woman, can go for MTP. So what are the differences between MTP and PCP and DT? See, one consultant may have many centers in PCP and DT and can go to many centers for MTP, sorry. And for one may perform MTP at any center which is recognized or approved by the center. There is no regular inspection in MTP. There is no need of renewal. If once the place is approved, it is approved for life. But if you are found punishable, then it is a non-bailable and cognizable or a non-compoundable punishment, and a rigorous imprisonment for 2 to 7 years with fine is what is there in MTP Act. So why is USG important in MTP Act? It tells us whether the pregnancy is uterine, intrauterine, extrauterine or heterotopic, the gestational age, if there are any structural fetal abnormalities, the liquor, then the pelvic and fetal head measurements, placental position and structure, and we can accordingly plan and prepare for the forthcoming situation so as to avoid mishaps to the patient or their life. So let us join hand together for safety of each and other. Let us join our hands together for safety of each mother because she matters to us. Thank you so much.
So requesting our chairpersons for expert comments.
Thank you, Rachna. That was wonderful.
Thank you, Dr. Rachna. Thank you, Dr. Rachna, for nice presentation. Just want to know that is there any list? What are the congenital malformation in which we can terminate the pregnancy?
Ma'am, right now there is no specific list which has been prepared where there certain indications are given that this pregnancy can be terminated. But yeah, if it is a life-threatening condition, and usually what people tend to do is they take the opinion of the pediatric consultant, and if they find that it is incompatible with life, then they can for termination of that pregnancy.
Because many times we have to take the opinion of the pediatrician. That's why I was. Okay, excellent. We have revised the revision of the amendment. Thank you.
Thank you, Rachna ma'am. Hello. Hello.
Yeah.
Yes, ma'am, you are audible.
Good evening to all of you. And my namaskar too. I am the secretary from the Bulla Uji Society. First of all, I like to thank Dr. Rachna ma'am for nice presentation. Very nicely, she has included all the things in the MTP amendment, along with the indications, the forms, the rules, the ultrasonography findings, everything she has mentioned very well. And I congratulate her for presenting this topic. And I am a master trainer in the comprehensive abortion care in our center. What I have found that is everything is okay. The service provided is okay, but a little bit we are lagging in the documentation part. So it is very much important. Whatever you are doing, the documentation part must be done 100% for the legal purpose. This is only one message, extra message from my side, and I thank all the committee members, special to Rasmi Kohar Madam, Rachna Madam, Sujit Sir, Nibha Madam, everyone for giving me this opportunity.
Doctor, in missed abortion or incomplete abortion, is there a need of any paper?
No, ma'am. In missed abortion or incomplete abortion, that will be registered in the admission register. It is not under the, if you are inducing any abortion, then it will be all the forms is required. Otherwise, not required.
Okay, thank you.
Thank you, Leena madam. Thank you, Dr. Anjana madam. I think Dr. Biswajit is also with us. Okay. Dr. Biba Chaudhary madam. Madam has logged in. Okay, so shall we conclude, Rachna?
Yeah, I think so, ma'am. We are done with the. Can technical person tell us if there are any question answers in the chat box with the delegates that have joined, or else we can conclude with the session.
I don't see any question.
I think it's clear.
Clear and very comprehensive. Thank you, and that was such a wonderful plan B, Rachna. I must congratulate you, and we all appreciate you very much. On time, you could manage.
Really a nice talk, Rachna.
Very good.
All the best
Thank you,
for
Rashmi and team, Rashmi, Ranjana, Sujit, everyone, and the Amogs team. Thank you for making part of this, and all talks were so good, and it was the session was convened so beautifully by all the conveners. So thank you all, and wishing all the best to you, Rashmi, Sujit.
We wish you all the best.
All the best, ma'am.
It was so wonderful.
Thank you, Leena.
Hi, Rashmi. I stayed back till the end to hear all your talks.
Yeah, that's
All the
very nice.
best, Dr. Sujit, to you also. And Rashmi, of course, to you and Dr. Nibhadi.
Thank you. Thank you.
She is from our society, Dr. Nibha Mohan. So I'll request all of you to vote for Shobha, madam.
Sure. Yes.
Thank you so much to our most beloved and dear most Shobha madam. She's our most beloved teacher.
Yes.
Definitely, Rashmi. You need to be supported. Why not? And youngsters like you should come up indeed. And my best wishes to Nibha also for her, and of course to Dr. Kondkar also. Definitely it will happen. Thank you.
Thank you. Thank you.
Bye-bye.
Thank you. Bye-bye.
Thank you so much, and wish you a very good evening and a very nice time.